What are the uses of headgears? This is the orthopedic effect. The forces applied onto the maxilla can be used to restrict its downward and forward growth. The distal force is such a case should be applied through the center of resistance of the maxilla. It has been suggested that forces in the range of 300 to 450 grams on each side for a minimum of 12 to 14 hours per day are required. Orthopedic effects from extraoral forces are best tapped in the pre-adolescent years. Encourage augmentation. Extraoral forces are used to reinforce anchorage when these obtained from the intraoral sources are insufficient. The headgear should be worn for approximately 10 hours per day. For this purpose, and force values of 300 grams per side are usually sufficient. In the maxilla, anchorage reinforcement is achieved by restricting the mesial movement of the molars. Distalization of the molars. Distal movement of the upper molars may be required for correction of the molar relation or to gain a space for the correction of crowding or retraction of the anteriors. Extraoral forces can be effectively used for this purpose when worn for a minimum of 14 hours per day. Unilateral distalization of the molars can be achieved using extraoral force by varying the length of the outer bow. The larger force is applied onto the side of the longer bow. Asymmetric headgears used for the above purpose are general cervical or combination type. Molar rotation. In order to derotate the molars has to be banded with a buccal tube placed distally and then subsequently repositioned. Correction is achieved by the adjustment of the inner bow so that it produces a rotational force on the molar. As soon as the correction is achieved, the face bow should be readjusted to apply a direct distal force. Space maintenance. A most effective method of maintaining the arch length is by the use of extraoral forces. The mesial movement of the molars is prevented and the face bow does not interfere with erupting teeth. In this situation, daily wear of approximately 8 hours is sufficient. Coming to the face mask. Headgears are used generally for the purpose of reinforcement of anchorage or for maxillary distalization. However, when an anterior protractory force is required, a protraction headgear is used. Face mask therapy has gained popularity in the last decade, and the principle of pulling force on the maxillary structures with the reciprocal pushing force on the forehead or the mandible through the facial anchorage is simple and mechanically sound enough to be used as a therapeutic procedure for the treatment of prognathic syndromes, maxillary retrusions, cleft and mandibular prognathism. Hickam in 1972 claims he was the first to use reverse headgear. However, this modality was made popular by Dallaire around the same year. A reversible headgear basically consists of a rigid extraoral framework which takes anchorage from the chin or the forehead or both from the anterior traction of the maxilla using extraoral elastics which generate large amount of force up to 1 kilogram or more. Indications: it can be used in growing patient having a prognathic mandible and a retrusive maxilla. It aids in pulling the maxillary structures forward and pushing the mandibular structures backwards. It can be used for bending the condylar neck for stimulating temporomandibular joint adaptation to the posterior displacement of the chin. It can be used for selective rearrangement of the palatal shelves in cleft patients. It can be used in correction of post-surgical relapse of the osteotomes, and it can be used to treat certain accessory problems associated with nose morphology, such as lateral deviation. Sites of anchorage. The anchorage for the purpose of the maxillary retraction can be obtained from the forehead, chin, or from the forehead and the chin. Anchorage from the chin. In this type, the protraction headgear, which is commonly used in Britain, chin cup with hose are employed. As the anchorage is employed, solely from the chin, the force is transmitted to the condylar cartilage and thereby has a disadvantage of altering the growth of the mandible. Anchorage from the skull. Certain forms of reversible headgears obtain an anchorage only from the forehead. The disadvantage include vision discomfort while sleeping, cost and time required in the fabrication and fixing. Anchorage from the chin and the forehead. This face mask makes use of anchorage from both the forehead and the chin. Anchorage is spread over a larger area. Thus, no excessive force is exerted onto the growth cartilage. However, the disadvantage with this appliance are difficulty in speech and compromise in aesthetics and comfort due to its small size. Coming to the biomechanical consideration, the amount of force required to bring about skeletal changes is about 1 pound per side. Direction of force, most authors recommend 15 to 20-degree downward pull to the occlusal plane to produce a pure forward translatory portion of the maxilla. If the lines of force is parallel to the occlusal plane, a forward translation as well as upward rotation takes place. Duration of the force, the time to achieve desired results is proportional to the amount of force utilized. Low forces take 13 months to produce desired results. However, very high forces like 1600 or 300 grams reduce the treatment time from 4 to 21 days. Frequency of use, most authors recommend 12 to 14 hours of wears a day. Parts of a reversible headgear. The reversible headgear consists of the following parts. One is the chin cup. Most protraction headgears obtain anchorage from the chin as well as the forehead. The chin cup is used to take anchorage from the chin area. It is usually connected to the rest of the face mask assembly by means of metal hooks. The chin cup can be ready-made or can be fabricated from an impression of the patient's genial region. Forehead cap. The forehead cap support of cap or strap is used to derive anchorage from the forehead. Elastics. Elastic post is used to apply a forward traction on the upper arch. Vertical posts of the chin cup are used to attach the elastics onto the molar tubes or hooks soldered onto the arch wire. This sort of traction is purely for the tooth movement. Intraoral appliances. The most commonly used protraction device is a multi-banded appliance with a rigid wire. Traction hooks are placed whether in the molar or the premolar region. McNamara advocates a banded army along with the protraction device, which more or less resembles the banded herbs appliance. Metal frame. The main component of the face mask assembly is the metal frame. It connects the various components such as the chin cup and the forehead cap. It also has provision to receive elastics from the intraoral appliances. The design of the metal frame differs based on the type of face mask. Types of reversible headgears. One is the protraction headgear by Hickam, which was developed in the early 60s. The force distribution is 12% to the head, 80%, 85% for the chin, and it consists of 2 short arms in front of the mouth to engage the maxillary protraction elastics. Also has a chin cup from which originates 2 long arms. The 2 long arms run parallel to the lower border of the mandible and go vertically up from the angle of the mandible and behind the ears. An elastic strap is attached to the end of the long arms to encircle the head. The advantage is better aesthetic and comfort than others, with the option of unilateral force applicability. Delaire type of face mask, which was popularized by Delaire in the 60s and uses the chin and the forehead for support. The appliance is made up of rigid wire framework, which is squarish and kept away from the face. It has a forehead cap and a chin cup with the wire running in front of the mouth used for elastic attachments. The Tubanger model. This is a modified type of delay face mask, and it consists of a chin cup from which originate two rods that run in the midline and is shaped to avoid interference of the nose. The superior ends of the two rods house a forehead cap from which the elastic encircle the head. Petit type of face mask. It is a modified type of Delia face mask. It consists of a chin cup and a forehead cap with a single rod running in the midline from the forehead cap to the chin cup. A crossbar at the level of the mouth is used to engage the elastics. Next is the chin cup. The chin cup or the chin cup cap is an extraoral orthopedic device that covers the chin and is connected to the headgear. It is used to restrict the forward and downward growth of the mandible. The chin cup face bow assembly consists of a chin cup, head cap, and an adjustable elastic strap that connects the chin cup with the head cap. Types of chin cups. One is the occipital full chin cup and the vertical full chin cup. Occipital full chin cup. This type of chin cup derives anchorage from the occipital region of the head. It is used in class 3 malocclusions associated with mild to moderate mandibular prognathism, and they are successful in patients who can bring their incisors close to an edge-to-edge position at centric relation. They are also indicated in patients with slightly protrusive lower incisors as they variably produce a lingual tipping of the lower incisors. Vertical full chin cup. This type of chin cup derives anchorage from the partial region of the This type of chin cup derives anchorage from the parietal region of the head. It is indicated in patients with steep mandibular plane angle and excessive anterior facial height. These patients usually exhibit an anterior open bite. Force magnitude and duration of the wear. At the time of appliance delivery, a force of 150 to 300 grams per side is used. Over the next 2 months, the force is gradually increases to 400 to 700 grams per side. The patient is asked to wear the appliance around 12 to 14 hours per day to achieve the desired results. Thank you.